Thank you so much for the invitation. It's always such a great course and always great to learn from so many awesome people. I've been listening to some of the discussion. It's been very interesting hearing various things about pelvic fixation, and hopefully I'm actually going to introduce some more points of controversy today that we can discuss further. And let's see here, my disclosures. And then, of course, we're all familiar with general reasons to use pelvic fixation, but what is more open for debate is how many points of pelvic fixation do we need? How many rods do we actually need for a deformity construct? And again, I'd just like to go in a little bit of detail later in the lecture, just about some placement tips for more than 2 points of pelvic fixation. And I'll actually focus on more than 2 points of a sacroiliac iliac trajectory rather than iliac trajectory, because that's been spoken about a lot already. And then just briefly at the end about preventing complications and some salvage options as well. So, of course, as we all know, L5S1 has a high amount of mechanical strain. The sacrum is mainly cancellous bone. And if we use iliac cortical bone, we decrease our S1 screw strain. So that's great. And one of the things that we don't know a lot about is what is the actual effect on the sacroiliac joint of having screws in the sacrum connected to screws in the ilium and not fixation across the SI joint itself. And conversely, what is the effect on the SI joint of having screws that cross the SI joint but don't necessarily fuse it? So those are the subjects of ongoing research so we can understand a little bit more about what role SI joint pain plays in these deformity patients. And so the common indications for pelvic fixation that we all use are constructs, higher than L2 if we're doing a large deformity correction, high-grade spondies, unstable sacral fractures. I would add to that list additionally, if a patient is osteoporotic that has a shorter level fusion, we might use pelvic fixation. And of course, if someone has failed S1 pedicle fixation, we often use pelvic fixation for a bailout. And the evolution over time of what we've used has really, beginning with the Galveston rods and all the way down to using multiple points of pelvic fixation with 5 rods and 5 spinal rods. And then, of course, we do have a role for transiliac transsacral screws, mainly in sacral fractures. So when I'm trying to decide what kind of pelvic fixation I'm going to place, I like to make things very simple. So I just use a sort of a simple menu. And to me, I think of, pelvic fixation as being placed from a medial to lateral trajectory versus being placed from a lateral to medial trajectory. And on the right side of the screen there, essentially, if I have a sacral fracture, I'm using lateral to medial and I'm trying to do a transsacral transiliac screw. As long as the sacral fracture is not displaced, that's a really highly effective strategy. And if I have a patient with pure SI joint pain that maybe is coming to me previously has had a solid fusion and their alignment is good, then I might choose to do a minimally invasive approach from lateral to medial across the SI joint. So those are the options on the right. And then the options on the left, of course, we can do fixation that we attach to rods or standalone fixation like an SI joint implant that we place from medial to lateral that we don't attach to rods. So there are lots of different, options here. And of course, there's always going to be a debate about S2AI versus iliac screws. Is one superior to the other? And probably the truth is they both have their upsides and downsides. And I don't, obviously anymore with the modified iliac trajectories, it's not really a concern for wound healing like it used to be. And many times we don't often require offset connectors even for iliac trajectories. So really the debate, I think, is going to come down to what is happening with the SI joint and can there be an implant that will prove better over time to help with SI joint related pain in patients that get it? So to me, that's what this distills down to, at least in 2024, although I understand this will be a debate we're having for a long time. So I just wanted to show you 3 cases of mine and how my practice has evolved and talk about the evidence that I'm trying to use for how to evolve it further. So the x-ray on the left is a case from 2014. You can see long construct. It was a significant deformity correction and 2 points of pelvic fixation and 2 rods total. And then in the middle, that was about 2018, 4 points of pelvic fixation, 4 rods. And then the case on the right was 2020, so 5 points of pelvic fixation and 3 rods. So you see quite a variability in what I'm doing. And I like to make sense to my own practice and think about why I'm doing something. So I think, in understanding what menu to choose from and how many points of pelvic fixation and how many rods, it really goes back to what are you trying to prevent? There have been a lot of studies on what happens long-term with pelvic fixation, and they have really variable results. So everything from pelvic fixation does really well and has a low revision rate to there's a 35% failure rate for S2AI screws in a certain study. So I think the first thing to recognize is that S2AI screws versus iliac screws have different mechanisms by which they fail. And that's intuitive because the stress is at different points. For S2AI screws, the failure mechanism typically is going to be a dislodgement of the set plug and or a sacral fracture along with that. And for iliac screws, if you've used an offset connector, of course, that's the weakest point there. But it's very rare that you actually have an iliac screw fracture itself, but the screw head interface would be vulnerable if you're going to have a fracture. And usually we just see a lot of loosening. So you might see loosening that's asymptomatic, large halos around the screws in a patient that's doing fine. And most of us would say we wouldn't do anything to revise that. Or you might see a patient who has pain that you can't really block out well with various diagnostic injections and who has haloing around the pelvic fixation. The question is that symptomatic pelvic fixation failure? And we don't define that, by a standard definition right now, but that's certainly going to be something I think important with time. One thing that I focused on with research is what happens acutely when pelvic fixation fails and what patients have acute failure. And when I say acute, I mean within 6 weeks of the index surgery, a patient that has a failure. Is there anything that we can do to predict that? We're seeing quite a high rate in my former position at the University of Minnesota, 5% of patients having failure, and these were all deformity patients. And these were all S2AI screws, and the failure mechanism was dislodgement of the set plug from the S2AI screw with or without a sacral fracture. And so we decided to do a multi-center study after seeing this finding in our own institution. And what we found after involving 13 medical centers across the country was that really the failure rate is 5%. So that is quite high when you think about what you might typically be telling your patients about, distal failure. I know a lot of us would counsel our patients about proximal junctional failure, the risk being quite high. But there's also a pretty significant risk of distal failure as well. And so when we looked at what was happening with these patients, what we found was that, a lot of these had high pre-op PI, which you're not going to be able to change a patient with high PI. And they're having large magnitudes of deformity corrections, and the screws were relatively smaller, less than 8.5 screws. But on the multivariate analysis, what we really pulled out was that not having a 5.1 interbody was a predictor of failure, and having a higher pre-op T1PA, which would indicate a larger deformity, was also a predictor of failure. And the other two I can't explain well. I think the implant manufacturer thing is something to ignore for now because that was mainly out of a single center, so we have some bias with that. And I certainly can't explain the male gender coming out, so we're going to have to look at that further with more patients. But I think these are things that start to pull our attention to what patients might need more than 2 rods and more than 2 points of pelvic fixation. When I put in S2AI screws, it's very easy to get the rod accommodated to the screw if I use an open head screw and tilt the screw head. These screws have high variable angles. They accommodate the rods easily. And it's not something that I used to think about inside of surgery. How far am I angling the screw head to get the rod in? Because to me, it just seemed fairly easy to do. But there have been multiple studies now, and this is one of them, that show that the more that you tilt an open screw head to accommodate the rod, you're actually changing the displacement force on the set plug. So you're actually increasing a point of strain that will lead to set plug failure more so. Of course, you can obviate that by using closed head screws, and that gets rid of this issue. But as all of us know, sometimes closed head screws, when you're trying to line up multiple points of pelvic fixation, can cause a challenge for accommodating just one rod. So it also turns out that how you torque off your set plugs actually affects the retention rate of how much is actually retained in the set plug itself. So if you're torquing off fast, which many of us might use as sort of a powered or motorized set plug torquing device to save our hands and wrists, it turns out that you're actually having a weaker interface with the retention of the torque than you are if you're torquing off slowly by hand. So that was just something interesting that we first noticed in a lab and are looking at more, trying to look at more in vivo. So when we think about how many rods are actually needed, as usual, Jens has written a paper that helps us define the problem and it helps us start to get to a solution. So this is a paper from 2022, just defining the different terms about how many rods and what type of rods there are. And I just want to stress that this conversation is not talking about how many rods do you need across a 3-column osteotomy. All of us would say you need more than 2 rods across the 3-column osteotomy. So this discussion of how many rods are needed is actually for a deformity without a 3-column osteotomy. And just pointing out this paper here, so this is a cadaver-based study that all had L1 to pelvis instrumentation. And the variability that was used was either using A-lifts at 4.5 and 5.1 with 2 rods, those A-lifts plus 4 rods, the rods from L3 to the pelvis, versus just 2 rods and no inner bodies. And so as we might predict and understand, the 2 rods with no inner bodies, the highest stress is at L5S1. Okay, that makes sense. And interestingly, the 2 rods with the A-lifts and the rods seated from L3 to S1 increase the rod strain across L3-4, which does make sense. But if you used 4 rods and you had them from L3 to S1, then you had a decreased strain on the primary rod that went all the way up to L1. So it would suggest, based on this paper, that if you use multiple A-lifts, that you should have a rod that spans not just the A-lifts, but to one level above with 4 rods, and then, of course, your principal rod. So that was just something, there are very few studies exactly on this topic, but this was one of the ones that actually had some data. And of course, there needs to be a lot more work done on this. But Dr. Lenke published from his group multi-rod constructs and what patients tend to have failure with multiple rods. So these were all patients who had more than 2 rods. They all had more than 10 levels fused to the pelvis. And so of these patients who had multiple rods, they had between 3 and 5 rods each. And what they saw was there was a pretty high rate of rod fracture, even with these multiple rods. The highest, of course, with the patients who only had 3 rods, not 5 rods. But the risk factor that got pulled out there was actually coronal correction, not SVA correction. And you might criticize this a little bit by saying that maybe SVA wasn't the best way to measure the amount of sagittal correction, and maybe if it was looked at in a different way, the amount of sagittal correction might have more bearing on this. But what was very clear was correcting any significant amount of coronal alignment resulted in a higher risk of rod fracture for 3 rods. So if you use, more than 3 rods and you're extending, the next question is, how high do I want the rod to extend? Where do I need for it to go? And that's something that we don't really have a clear indication of as of right now. So many of us, what we'll do is kind of do what makes sense when we're in the OR or something that's intuitive. But it might not be consistent from patient to patient. It might be just the best solution for that patient. So in my mind, when I'm going to do more than 2 points of pelvic fixation and more than 2 rods, in my hands, and I have no evidence for this, it's when I'm going above T12 to the pelvis. And typically I have inner bodies, all the way up to probably L1, 2 in most of these patients. And so to me, if I'm going to have rods that are extending without inner body support, I want to make sure I have a 4-rod construct there. Of course, we talked about 3-column osteotomies. We're all going to use multiple rods. And, coronal plane correction is something that I really started paying much more attention to over the last 3 years as far as using multiple rods. And patients who have long lever arms in their spine, like ink spondy dish patients, I always use 4 rods just because there's a lot more force there than the levels might otherwise portend. And then a malaligned sacral fracture does much better if you have multiple points and multiple rods as far as stability. So that's just the quick indication about when do I think we need more than 2 pelvic fixation points and when do I think we need more than 2 rods. But we really need to understand this in a defined way, and that's something that's not currently existing in our literature. So I just want to move forward a little bit, and I want to talk about S2 AI screws when you're putting in dual pelvic fixation points on one side using a sacroiliac iliac trajectory. And I know we talked a lot previously about how to do that with pure iliac screws. And so the first thing that I usually think of is, in the S1 pedicle screw can go almost anywhere. The S1 is a huge pedicle, but you really set yourself up for success of putting multiple points of pelvic fixation in, actually, when you're putting your S1 pedicle screw in. And I usually do put an S1 pedicle screw in with these dual points. I don't skip it. And I don't have great biomechanical evidence as to why. I don't think you absolutely have to have it, but certainly with this technique, you can easily accommodate it. And so what I'll do is put the S1 pedicle screws as cephalad as possible in the S1 pedicle, while still, of course, putting them in the correct trajectory to engage the sacral promontory and get optimal purchase. But what I don't want to do is start low in the S1 pedicle and angle up towards the promontory, because then my S1 pedicle screw heads are going to interfere with where I want to put my pelvic fixation points. So if I'm planning to put 2 S2 AI screws on each side, the next thing that I'll do after the S1 pedicle screws is I'll put in the most caudal point of fixation. So that caudal screw head for the S2 AI trajectory is going to be more medial, because the sacrum, of course, is triangular shaped and tapers down as you go more distally. So the starting point for the caudal screw is more medial. And I'll basically aim right to engage the bone right above the sciatic notch with that screw. and then I'll place the more cranial of the S2AI trajectories, and that will basically parallel the other and will be right around the iliopectineal line. And as far as rod capture rates, you absolutely can line these up to all be in one rod. I typically am using the 4 points of pelvic fixation when I have more than one rod on each side. So in order to accommodate 2 rods on each side, I find it helpful to leave the caudal implant slightly prouder and the head actually just purely medialized. And I'll do that with a closed screw head, so I'm not toggling that around to engage the rod. And then with the more cephalad implant that lies more laterally, that's the one that I'll line up with the S1 pedicle screw and most of the pedicle screws. And my typical workflow is to use a 4-rod construct. I'll tie in that medial rod with a dual head pedicle screw farther up in the construct. And that would vary from patient to patient depending on the coronal alignment as far as and the sagittal alignment as far as how high up I want that dual headed pedicle screw to be. Of course, you don't have to use dual headed pedicle screws. You can just easily use an offset connector as well. But I think we really need to do a study to understand if there is a biomechanical advantage to a dual headed pedicle screw versus, an offset connector as far as the strain itself. But I don't know the answer to that. That's just my own preference, is not to use connectors whenever possible. What I would tell you about how to place these 2 points of S2AI screws is that you need about 15 millimeters in between the screw heads to make sure that you're going to be able to have rod clearance from both. And so that's just, kind of a hard learned lesson is from the type of implant that I use. Every manufacturer is slightly different. So I imagine there would be situations where you could need less clearance, but that's just in my own hands, my own experience. And so we talked, very briefly about this. The S1 pedicle screw gets connected to the cephalad-most S2AI screw, and then I run a rod medially from the caudal screw up to a dual-headed pedicle screw higher up in the construct. And of course, using 3D navigation is not absolutely necessary to do this, and it's perfectly fine to do this without. But if you're having a complex revision case, such as in this patient who came to me who had 3 SI joint implants on one side, and it was not going to be trivial to take those implants out. The patient had a different indication for having this pelvic fixation and a major coronal correction. But so working around those using CT-based navigation certainly makes your day easier. Otherwise, it's 90 fluoro shots to figure out how you're going to get around those implants that are existing. So I, of course, recognize that you don't have to use CT-based navigation to do this, but there are a lot of times when it can make your life significantly easier. And I just would say, whenever you're placing these with navigation has inaccuracies. And one of the reasons it does is because the farther you get from the frame, of course, the less accurate the navigation will be for frame-based navigation. So specifically, these screws that I typically will put in 110, 120 millimeter screws. And as the screw is crossing the SI joint, that's the most likely point where it's going to skive anteriorly into the retroperitoneum. And your navigation might not catch it. So I think it's just critical if you're using navigation, to do this procedure, that you're still really mindful about making sure when you're crossing the SI joint to be very mindful about where your hand is. And usually what I'll do is just gently, change my trajectory, push my hand down towards the floor a little bit so that I'm not as great of risk of skiving anteriorly. And so just to show you what this actually looks like, we won't go through this whole video, but I'll just draw your attention to these navigation windows here. And here we're showing the trajectory right above the sciatic notch when it goes green again, as far as where the implant trajectory for the lower screw is going to be. And the workflow here, and there are many great workflows with navigation, this is just one that has worked really seamless for us, is we typically will use a navigated awl to go down to the SI joint, but not across it with that awl, for the reason that it's easy to skive with a blunt object when you're trying to cross the SI joint. So then I'll navigate with a drill across the SI joint itself. And of course, using a ball-tipped probe into between these steps after the drill to make sure that I'm in an appropriate trajectory. And then I typically will tap 6.5, 8.5, 10.5, and 10.5 diameter is the size of screw that I'll put in. And then because this is the caudal most of the implant, I'll leave the screw head slightly proud, as we talked about, and being careful to make sure if it's a very thin patient, I won't do that. I don't want any chance of implant prominence, but leaving the caudal screw head slightly proud. And then that allows some freedom to actually, toggle that screw head to accommodate a 4th rod or 2 rods on each side, essentially. So you can see from the navigation trajectories as we go along, as we place that caudalmost screw, and here is coming the screw in itself, aiming parallel to the sciatic notch and trying to engage the bone right up against the edge of it here. You can see that. And then you can see the actual screw head technique, and just here we'll leave it just slightly prominent, just a little bit. So we've got a little bit room to angle it medially without too much screw head angulation. So we'll just move on from there. I just wanted to highlight, what one of those possible workflows would be. And of course, there are many you can use. And when you look at your CT scan, for those of you that question whether you can have S1 pedicle screws and then 4 points of pelvic fixation, here's a CT scan showing a typical average case of doing that. And that's very, very easy and very typical to do. And then, I think that when you are considering what exactly the patient needs, I can't tell you that using 4 screws that cross the SI joints results in a superior outcome. But just like Dr. Islak mentioned earlier, I think there is some consequence of ignoring the SI joint entirely as far as pain. And so all of us have patients who have done really well and we've never thought about their SI joints and never need to. But I think that on average, the amount of strain we're putting on the SI joint is significant, and I think we don't understand completely the consequence of that as of right now. So just to say one more thing about complications, I think that patients who have transitional segment anatomy give me great pause as far as how to be, I am very careful with their pelvic fixation. So I've had a patient who had a low PSO and had transitional segment anatomy and had quite a catastrophic sacral fracture through what was a previously non-mobile disc space at S1, S2. So I just want to, impart caution if you haven't encountered those patients, that they definitely need to have multiple points of pelvic fixation placed very carefully to involve more than just the transitional segment. So to me, in my hands, how I try to think about preventing fixation failure, obviously we're all going to start by getting the sagittal alignment right. And I will always use an interbody at 5'1" when I'm doing a deformity, no matter whether I'm doing it posterior or anterior. My pelvic fixation screw diameter is always bigger than 8'5", and standardly it's 10'5". If I'm revising a failed screw, you can have custom implants much larger than that. I will always use more than 2 points of pelvic fixation for these larger cases connected to more than 2 rods. I'm very careful about the angling of the S2AI screw, or I'll use a closed-headed screw if I think I need to angle it, just to avoid the set plug pop-off mechanism of failure. And I'll tighten the set plugs on the pelvic fixation by hand to help retain the torque better than by an automated torque off that I might use for the pedicle screws themselves. As far as salvage strategies, I think that navigation is very helpful when you're trying to salvage failed pelvic fixation. I will try to retrieve fractured screws if they're fractured proximal to the SI joint. Then I'll try to trephine around them and grab them and with a plier or with a trephine and back them out. I think that is worthwhile in patients where you really need to get 2 fixation points back on that side if they've already had multiple iliac trajectories as well. Sometimes I'll leave a screw fragment in if it's across the SI joint if I can get good iliac trajectory screws in. So it just really depends on the patient itself. And when I'm thinking about putting more than 2 or more S2AI screws on one side, I'll always put the caudal implant first so that I can get as low as possible across next to the sciatic notch, and then place the more cephalad implant. So thanks for your time. I really hope to keep us on track here time-wise, but I just want to say, as all of you go back to your home institutions, I just wanted to mention our fellowship program at Duke. It's absolutely phenomenal. I have amazing partners, great educators. So those that you train and those that you talk to who are interested in fellowship, keep us in mind. I think we have a great fellowship and we're always looking to make it better.
Great overview, Kristen, and thanks, really appreciate it, and thanks for your time and contributing for us. I see you're using a lot of the SI bone screws in the thing. How strongly do you feel that besides those screws, do formal SI joint fusion should be done? I feel very strongly about an S1 screw to offset the iliac fixation, and I was just wondering your comments on that as well. I know you brought it up a little bit.
Yeah, thank you. I think that the first thing I'll say is we're not positive that these bone ingrowth screws result in fusion across the joint. We can't quite prove that yet in patients. I have revised one that did have bone ingrowth across the screw and had to be completely explanted. So if I'm going to have a screw that can fuse across a joint, then I do think that's advantageous. And that's something that I'm hoping to see more as we study these bone and growth screws more that cross the SI joint themselves. I do always put an S1 pedicle screw in, even with the sacroiliac trajectory, for the reason that you mentioned. You like to have as much engagement of the cancellous part of the sacrum as possible for stabilization. So I think, I always do the S1 pedicle screw. I know others don't. They'll just do the points of pelvic fixation. But for me, I always use the S1 pedicle screw also.
Great. Well, thank you for the great talk. One of the things that I think you brought up with that kind of transitional anatomy down in the lower lumbar spine, obviously with a pre-op CT, you can see there's kind of some nuances there. What are some of the challenges that you see in terms of being able to get, if you do want to get those 4 points of fixation in the pelvis?
Yeah, I think in patients with transitional segment anatomy, I think your starting points are certainly altered slightly. And it's easy to see that someone has transitional segment anatomy even on a plain X-ray. So I think that's something you can catch without a CT scan. I think if you're not going to use navigation in the OR, then it is really helpful to have a CT scan ahead of time, because often what you'll find, what I have found at least, is that my second point of fixation actually is quite a bit lower than I would expect it to be, just because of the dysmorphism of the sacrum. So I think that being aware of that ahead of time is really helpful. And when you're using fluoroscopy to place screws in a dysmorphic sacrum, of course, you're going to do the same safety checks and steps that you normally would, but just knowing in general what exactly that looks like in that particular patient is helpful.
Great, thank you so much. Any other questions? All right, well, thank you for your time and for being with us again.
Thank you.